Welcome guys. Let's discuss about the fundamental concepts of epinephrine and norepinephrine. These two drugs are among the most important life-saving drugs, particularly in emergency and critical care medicine. So our lecture includes the main difference between epinephrine and norepinephrine, their mechanism of action, biosynthesis and catabolism. Epinephrine and norepinephrine are both catecholamines that act as hormones and neurotransmitters, but they exhibit distinct activities largely due to their receptor affinities and consequent physiological effects. Here it is the structure of norepinephrine and it is the structure of epinephrine. Catecholamines are a group of neurotransmitters and hormones that include dopamine, norepinephrine, and epinephrine. They play a crucial role in the body's response to stress, mood regulation, and autonomic nervous system function. So disturbances in the levels of catecholamines in our body results altered level of stress, mood, and autonomic nervous system function. Now let's see the biosynthesis of catecholamines. Catecholamine biosynthesis occurs in adrenergic and dopaminergic neurons in the central and peripheral nervous system and adrenal medulla in the adrenal gland. The process involves several enzymatic steps. There are 4 enzymatic steps in the synthesis of catecholamines. These are tyrosine hydroxylation, decarboxylation, hydroxylation, and methylation. On step 1, tyrosine hydroxylation, the enzyme tyrosine hydroxylase converts levotyrosine into levodopa. This is the rate limiting step in catecholamine synthesis. The second step is decarboxylation. Levodopa converted into dopamine by L-aromatic amino acid decarboxylase. The third step, hydroxylation. Dopamine is then hydroxylated by dopamine beta hydroxylase to form norepinephrine. The fourth and the last step is methylation. In the renal medulla, norepinephrine is further converted into epinephrine by phenylethanolamine N-methyltransferase enzyme. Here is a summary of catecholamine synthesis. So tyrosine, it is one of the aromatic amino acids located in our body, is converted into levodopa by the enzyme tyrosine hydroxylase, which is encoded by TH gene and particularly located in the brain, peripheral nervous system, particularly in the sympathetic neurons and in the adrenal medulla. So this enzyme uses tetrahydrobiopterin, oxygen, and iron as a cofactor. Then levodopa is decarboxylated into dopamine by dopa decarboxylase. And the third step is dopamine is converted into norepinephrine by the enzyme dopamine beta hydroxylase. And finally, norepinephrine is converted into epinephrine in the adrenal medulla by the enzyme phenylethanolamine N-methyltransferase. So this is a summary of catecholamine synthesis. Now let's see the catabolism of catecholamine. Catecholamine are broken down primarily by 2 enzymes, by the enzyme monoamine oxidase and by the enzyme catechol O methyltransferase. So monoamine oxidase oxidatively deaminates catecholamines inside neurons, and catechol O methyltransferase or COMT. This enzyme methylates catecholamines primarily in the bloodstream and extraneuronal tissues. So the main difference is monoamine oxidase, it is used oxidation, and the enzyme is located, the enzyme works in the inside neurons, whereas catechol O methyltransferase works in the bloodstream and extraneuronal tissues. There are a group of drugs called COMT inhibitors, acts on COMT enzyme and prevents further degradation of catecholamines, thereby increasing the levels of catecholamine in our body and used as treatments for anti-Parkinson disease and antidepressants. And there are also drugs called monoamine oxidase inhibitors which acts here, which also prevents further degradation of catecholamines in the inside neurons, thereby increasing the levels of epinephrine, dopamine, norepinephrine in the bloodstream, and thereby increasing and thereby treating diseases like Parkinson's disease and depression. So these enzymes are used for drug targets. The breakdown products include vanillyl mandelic acid, methanephrine, and normethanephrine, which are excreted in the urine. Catecholamines are essential for the fight or flight response, regulating heart rate, blood pressure, and metabolism. This dysregulation is linked to conditions like Parkinson's disease, depression, and hypertension. Now let's see the difference between epinephrine and norepinephrine by receptor binding and physiological actions. Epinephrine, its receptor affinity, epinephrine binds to both alpha and beta adrenergic receptors with a stronger effect on beta receptors, which are located in the heart, lungs, and skeletal muscles. So the physiologic effects of epinephrine is increases heart rate, enhances the force of heart contractions, dilates bronchi, raises the blood sugar levels. The overall impact is to prepare the body for a rapid fight or flight response, boosting alertness, energy supply, oxygen delivery to muscles. Now let's see the clinical importance of epinephrine. Because of these actions, epinephrine is used in emergencies like anaphylaxis, cardiac arrest, severe asthma attacks, where quick improvements in airway relaxation and cardiac output are essential. Now let's see norepinephrine. At its receptor affinity, norepinephrine primarily exerts its action through alpha receptors, especially those located in arteries, with less pronounced effects on beta receptors. This is the main difference between epinephrine and norepinephrine. We have seen that epinephrine is selective for particular selection for beta receptors, whereas norepinephrine is particularly selects alpha receptors. So the physiologic effects of norepinephrine is its predominant influence on alpha receptors causes vasoconstriction, which increases the peripheral resistance and raises blood pressure. Norepinephrine also contributes to basic sympathetic nervous system tone by maintaining consistent blood pressure and alertness in daily life. Let's see the clinical importance of norepinephrine. Owing to its strong vasoconstrictive properties, norepinephrine is often used in critical care settings like to manage severe hypotension and shock states, such as septic shock, where maintaining adequate blood pressure is crucial. This is a summary comparison of epinephrine and norepinephrine. Based on their receptor preference, we have said that epinephrine has strong action on both beta and alpha receptors, predominantly beta receptors, whereas norepinephrine predominantly acts on alpha receptors with minimal beta effects. Primary effects increases heart rate. Epinephrine increases heart rate, boosts contractility, dilates airway, and immobilizes energy. We have said that increases the blood glucose levels, thereby mobilizes energy, increasing our level of energy. And norepinephrine causes potent vasoconstriction, elevates blood pressure, supports vascular tone. Clinical application: epinephrine can be used in emergency treatments for anaphylaxis, severe cardiac arrest, and severe asthma. Cardiac arrest and severe asthma. And norepinephrine for the management of shock and hypotension. For example, septic shock, for the treatment of septic shock. Integrative perspective. Epinephrine wider ranging receptor activity drives a cascade of effects that primes the body for rapid physical exertion, making it ideal for acute stress response. In contrast, norepinephrine's focused action on vasoconstriction illustrates its role in sustaining long-term sympathetic tone by regulating blood pressure and ensuring a steady tissue perfusion. This tailored receptor activity explains why, despite their chemical similarities, their roles in both physiology and therapeutics diverges significantly. Thank you, guys. So we have so far we have seen that the mechanism of epinephrine and norepinephrine, their difference based on receptor preference, based on their clinical importance, and we have seen the biosynthesis and catabolism of catecholamines. Thank you, guys. Have a nice time.